Chapter 3, Understanding Your Residents. That is what it's about. It's not a bad chapter. A lot of people already know because you got this going on in your family. We just break it down in a different kind of way. But we're going to do Chapter 3, page 58, Understanding Your Residents. First, we got to identify our basic human needs. Mr. Maslow, he's a famous man who made this triangle that's over there on page 59. He says that your body, you have to do your physical needs before any of your other needs. So your physical needs are food and water, protection and shelter, activity, sleep, rest, and comfort. If you don't have those, you cannot move up the line to what's next. Also, people have psychosocial needs. You have to break down that word. Psycho meaning mind, social meaning friends, social things. Because your question you're going to be asked is, does food and water belong in the psychosocial category? No. It has nothing to do with your mind or your body. I mean, pretty much body. But it is a physical need. So I guess it really does have the mind, but it does not have anything to do with your psych or your social needs. It does have everything to do with your physical needs. So your psychosocial needs: love and affection, acceptance by others, safety, security, self-reliance, contact with others, success, self-esteem. Health and well-being affect how well psychosocial needs are met. Stress and frustration occur when basic needs are not met. This can lead to fear, anxiety, anger, aggression, withdrawal, indifference, and depression. Stress can also cause physical problems that may eventually lead to illness. Abraham Maslow was a researcher of human behavior. There he goes. He wrote about human physical and psychosocial needs. He arranged it in that paragraph, the triangle that we have there. They call it Maslow's hierarchy of needs. And if you just look at the bottom of there, it is your physical needs, your oxygen, water, food, elimination, rest. You have to have all that or you can't move to the next level, which is shelter, clothing, protection from harm, and stability. You have to have at least those two things to try to get a need for love. A lot of people, if you're not secure in your home, if you're not secure with a job or secure, at least feeling secure, you can't accept love. You're trying to still work on yourself, so problems arise from that. So they want you to follow these steps. Get your physical needs, then your safety, security, then comes your need for love. After that, you feel loved, you feel accepted, you can move on to need for self-esteem. That's your achievements, belief in your own worth and your value. And once you get there, you're a much better person because you feel worthy of yourself, or worthy of things that you need and can have. Then you move on up to the need for self-actualization. That's where you feel empowered. You know you can do things, and we're going to do everything we can to make ourselves better. In your life, whatever you feel is better. That's your self-actualization. Throughout this book, they keep on telling us that residents, Lordy mercy, that they continue to be sexual beings, and it's all the way through this chapter. Sexual urges do not end due to age or an admission to a healthcare facility. They make you know the definition of masturbation. We know what that means: to touch or rub sexual organs in order to give themselves pleasure or somebody else pleasure. That's masturbation. Residents have the right to choose how they express their sexuality. In all age groups, there's a variety of sexual behavior. This is true of all residents. You should not treat them any kind of way different. Always knock or announce yourself before entering a resident's room. You never know what you might walk into. If you encounter a sexual situation between consenting adults, provide the privacy and leave the room. Get gone. As long as they're consenting, that's what they want to do. Be open and non-judgmental. Respect their sexual orientation. However they feel. Love is love. Honor, do not disturb signs. When it says do not disturb, then you might have something going on in there. Do not disturb them. Do not view expression of sexuality by the elderly as disgusting nor cute. Know that they do have rights. Sexual abuse. Residents must be protected from unwanted sexual advances. If a nurse assistant sees sexual abuse happening, he should remove the resident from the situation and take the resident to a safe place. Then they should report the nurse immediately. First thing you do is remove that patient. You just don't go tell nobody and let it continue. You remove that resident first. Helping residents meet their spiritual needs can also help cope with illness. So now they go back to their spiritual needs, and respecting them. Learn about the residents' religion, beliefs, respect their decisions, even food-related decisions, not to eat. If they're religious, encourage participation. Respect all the religious items, underline that one. Report to the nurse if they express they want to see clergy, which is members of the church, or mostly, the deacons of the church, somebody important. Allow privacy for clergy visits, whatever. Clergy is anybody at the church, mostly the deacons, things like that. If asked, read religious materials out loud. If you're uncomfortable, find somebody else who's not. If a resident asks you, help find spiritual resources available in the area. Most of the time, you're going to refer that to the social worker, though. You should never do any of the following. Never try to change their religion. Never tell residents their belief is wrong. Never express judgments about a religious group, any group. Never assist they join religious activities, and never interfere with their religious practices. In healthcare, and especially nursing home care, we try to do a holistic care. Holistic means considering the whole system, and just like it sounds, but it is spelled HOLISTIC. But that is messing with the whole person, the mind as well as the body. A simple example of holistic care is that the NA talking to the residents while bathing them. You just don't bathe them and don't say a word to them. You talk to them also. Explain why promoting independence and self-care is important. Any big change in lifestyle, such as moving into a long-term care facility, requires a huge emotional adjustment. Residents may be experiencing fear, loss, or uncertainty, along with decline in health and independence. Other common reactions to illness are denial, withdrawal, anger, depression. All of these feelings may cause residents to behave differently than they have before. Each person adjusts to illness and change in his or her own way and is in his or her own time. It is important for NAs to be supportive and encouraging. NAs should be patient, understanding, and empathetic, because they may have changes. They may be the sweetest little person, but right now they're very upset because they can't do for themselves, or they're moving to a nursing home. They're upset. So give them that leeway. Moving to a care facility represents a tremendous loss of independence for a resident. Somebody else must now do what residents did for themselves all of their lives. It's difficult for residents, friends, and family members also. For example, a resident may have been the main provider for the family. They may have did all the cooking for the family. Other losses that the residents are experiencing is loss of their spouse, their family members, friends, due to death, because they've gotten old. A lot of people die. Loss of the workplace and its relationships for retirement. Loss of ability to go to their favorite places. Loss of the ability to attend services. Loss of home, personal possessions. Loss of health and ability to care for themselves. Loss of ability to move freely. Loss of their pets. A lot of times, lesbian, gay, bisexual, transgender residents fear the loss of that acceptance that they felt at their home or in their community. But we're going to accept them too. Independence often means not having to rely on others for money, daily care, or participation in social activities. People may take these activities for granted until they can no longer do them for themselves. When a person loses independence, these problems can result. Poor self-image, anger toward caregivers, others, and feelings of hopelessness, sadness, hopelessness, feelings of being useless, increased dependence, and depression. To prevent these feelings, NA should encourage residents to do as much as possible for themselves. We keep saying this over and over. NAs must encourage self-care regardless of how long it takes or how poorly they do it. Try to let them do it themselves. Allowing residents to make choices is another way to promote independence. Underline that. They can choose where they want to sit, where they want to eat, and what order they want to eat it in. That's their choices. Residents' rights for dignity and independence. Residents are adults. They should not be treated like children. NA should encourage residents to do self-care without rushing them. Residents have the right to refuse care and to make their own choices. Promoting dignity and independence is part of protecting their legal rights. Those are legal rights. It is also the proper and ethical way for you to work. Identify ways to accommodate cultural differences. The term cultural diversity refers to different groups of people with varied backgrounds and experiences living together in the world. So we are culturally diverse here in the United States. Positive responses to cultural diversity include acceptance and knowledge, not prejudice. Each culture may have different knowledge, behaviors, beliefs, values, attitudes, religion, and customs. It is important that NAs respect and value each person as an individual. They should respond to differences and new experiences with acceptance. And you are here to care for those people, no matter whether you believe in their religion or not, or anything. Their culture, their practices, that's not what you're here for. You're here to care for their body and talk to them. There's so many different cultures. They may not be, and they aren't listed here, but American culture is different than Japanese culture. But within American culture, there are thousands of different groups, such as Japanese Americans, African Americans, Native Americans. That's just a few. Even people with a particular region, state, or city can be said to have a different culture, just like the South is nowhere near as the people in the culture of the North. Culture background affects how friendly people are to strangers. It can affect how close they want to stand when people are talking. It can affect how they feel about NAs performing care for them or discussing their health with them. Sometimes I do know that Spanish people, you actually have to talk to the man first before you talk to the wife. And maybe the man doctor can't touch the woman doctor, the female patient. They've got their rules. Regardless of background, all residents must be treated with respect and professionalism. If he or she speaks a different language, an interpreter may be necessary. It can be helpful if staff learn a few common phrases in their language. Picture cards and flashcards can assist with communication. Again, refer to that page 84. It's a wonderful card. We can even use it if they can't speak the same language. Religious differences also influence the way people behave. Religion can be very important in people's lives, particularly when they're ill or dying. Nursing assistants must respect the religious beliefs and practices of residents, even if they're different from their own. They should not question residents' belief or discuss their beliefs with other residents. You keep their information to you. Many religious beliefs include dietary restrictions. These are rules about what they can or can't eat. For example, Jewish people do not eat pork. Some people's backgrounds may make them less comfortable being touched, so try to not touch them so much. You're going to have to, but just know that the touching too long may be eerie or weird to them. However, they should recognize that some residents feel more comfortable when there's little physical contact or a lot of physical contact. It just depends on where they're from or how they was raised or what they've been through. Could be traumas that they don't want you touching them. They don't want a man to take care of them. Culturally sensitive care. Culture, age, family, and background shape each person's way of thinking. It's important for NAs to ask questions to find out what is appropriate and to always respect residents' choices, beliefs, and behaviors. That is their right. Culturally sensitive care. That's what we need to provide. Describe the need for activity. We already know that if we don't have these people moving, they are going to be in trouble. We learned these little bit in each of these chapters. Activity is an essential part of a person's life. It improves and maintains physical and mental health. Meaningful activities help promote the independence, memory, self-esteem, and quality of life. In addition, physical activity can help manage illness such as diabetes, high blood pressure, high cholesterol. We got to keep them moving because activity lessens the risk of heart disease, colon cancer, diabetes, obesity. It also relieves symptoms of depression, improves mood and concentration, improves body function, lowers the risk of falls, improves sleep quality, improves the ability to cope with stress, increases energy, increases appetite, and promotes better eating habits. So, yes, the need for activity is well documented. However, if they're inactivity and immobility, it can result in physical and mental problems such as loss of self-esteem, depression, boredom, pneumonia, urinary tract infections, skin breakdowns, constipation, blood clots, dulling of the senses. We got to get them moving. OBRA requires that facilities provide an activities program that is designed to meet the interests in the physical and psychosocial well-being of each resident. The activities are created to help residents socialize and keep them physically and mentally active. Daily schedules are normally posted with activities for that particular day. Activities include exercise, arts, crafts, board games, newspapers, magazines, books, TV and radio, pet therapy, gardening, and group religious events. All kind of activities. When activities are scheduled, NAs should help the residents get there, help with grooming beforehand. NAs may need to help the residents get there too. They may help them walk or get them there with their wheelchairs. Discuss family roles and their significance in healthcare. Families play an important part in most people's lives. There are many different kinds of families, and you should try to remember each of these. Nuclear families, that's the two parents and one or more children. That's the white picket fence family. Two parents, one or more children. Single parent, that means one parent, one child, or how many of our children. Married or committed couples of the same sex or opposite sex, with or without children. That is That's two married people. They're married without children, or female to female or male to male, with or without children, doesn't matter. Those are married or committed couples. Extended families are parents, children, grandparents, aunts, uncles, cousins, other relatives, even friends. They call them extended. Blended is when two people, either divorced or widowed, come together and make a blended family, like pieces of two different families came together. That is your blended family. Often the family is defined more by supporting each other than by the particular people involved. Whatever kinds of families residents have, they have an important role to play. Family members help in many ways. They help residents make care decisions, communicate with the care team. They give support and encouragement, connect the resident to the outside world, and offer assurance to dying residents that the family members and traditions will be valued and carried on. That's kind of sad. I don't like this chapter for that reason, for the death part. But I do teach it. NA should be respectful to friends and family members and allow privacy for visits. After a visitor leaves, the NA should observe the effect that the visitor had on them. Any noticeable effects should be reported to the nurse. NAs must immediately report any abusive behavior from a visitor toward a resident to the charge nurse. Families are great sources of information. The NA should ask them questions. Families often seek out nursing assistance because they're closest to their residents. This is an important responsibility. We should ask them questions. Show families. The NA should show families that they have time for them also. Any questions about the care should be reported to the nurse. Try not to answer questions you don't fully know. But they tend to ask you a lot of questions because you're with their mother, you're with their grandmother most of the day, not the nurse. The nurse has to go and give medication to everybody. You are more familiar with your patient. Throughout their lives, people change physically and psychologically. Everyone will go through the same stages of development. However, no two people will follow the exact pattern of the rate of development. Each resident should not be treated as someone who is merely ill or disabled. They are different, but they follow that same pattern. Infancy. I want you to come on down to physical development. In infancy, moves from head down. For example, infants gain control of the muscles of their neck before the muscles in their shoulders. That's what's important. I'm going to give you the most important of each of these sections. They teach you this because you might take care of anybody in these age groups. Just because we're learning about long-term care, a CNA can work in a lot of facilities. A toddler, ages 1 to 3. During the toddler years, children gain independence. They learn new control over their bodies. Toddlers learn to speak and gain coordination of their limbs, and they learn to control their bladders and bowels. Toddlers assert their new independence by exploring poisons, hazards. And sharp stuff needs to be locked away, moved out of the way somewhere. They may try to get what they want by throwing tantrums, whining, or refusing to cooperate. I always say this is the key time. If you don't get them now, they may not know right from wrong, but they know mother doesn't like that, father doesn't like that, because you show them that they don't like that. If you let them throw tantrums and let them have their way, or don't follow through with no, you will pay for it for the rest of their life, the rest of your life. So make sure you get them at ages 1 to 3. Preschool. They're developing. They're getting all kind of new skills. They're learning new ways to socialize. They learn new words, language skills. They learn to play in groups. They become more physically coordinated and learn to care for themselves. They're getting better. They can do lots for themselves. I like them because they can go finally make them their own sandwich. But that's what preschool age is. They begin to learn right from wrong in preschool. School age is 6 to 10. Children development is centered on cognitive related to thinking and learning and social development. Right here at this time, they are like sponges. You can teach them and show them, and they are trying their best to learn everything. They get disappointed if they're not making straight A's. They want to please their mother. That is what they want to do. Plus, they want to have friends and be liked. Children learn to get along with each other. They also begin to behave in ways common to their gender. They begin to develop a conscience, morals, and self-esteem. That's 6 to 10, so watch out. Here they are becoming little people. Pre-adolescence, ages 10 to 13. Children enjoy a growing sense of self-identity and a strong sense of identity with their peers. They tend to be very social. Childhood fears of ghosts or monsters will give way to fears based in the real world. Excuse me. It is important that pre-adolescents feel able to trust in the attention and care of their parents and older adults, other adults, I should say. This is the age between 10 and 13. A lot of children get their trust issues because if they can't trust mother to come pick them up at 4 o'clock, like they said they would, then they learn that even mother lies. They're not going to tell you lied, but you didn't make it. You didn't come on time like you said you would, and they feel threatened. They feel scared. And they start learning that even mothers lie. When you used to not lie, you can tell a lie in the world. But they get their trust issues. So try not to tell them you're going to do something and don't do it. Adolescence, 13 to 19. Puberty is a stage of growth when secondary sex characteristics such as body hair appear, reproductive organs begin to function. It happens for girls 10 to 14 years old and boys 12 to 16. Peer acceptance is important to them. The concern for their body image and acceptance combined with changing hormones that influence moods can cause rapid mood swings. So that's what this age is. Rapid mood swings, they just know everything. Parents know nothing. Pressures develop as they remain dependent on their parents, but yet they want to express themselves socially and sexually. That don't mean they have to have sex, but with the opposite sex. This causes conflict and stress. They really want to be independent, but they don't have a job. They know they can't live on their own. They might even try to move out or run away. But they soon realize that they don't have any money. It takes money to take care of them. Young adult. Physical growth has usually been completed by this time. Adopting a healthy lifestyle in this age will help you in later adulthood. If you don't, you will be messed up in later adulthood. The task of these years is selecting an appropriate education, selecting an occupation or a career, selecting a mate, learning to live with a mate, raising children, developing a sex life, a satisfying sex life. In middle adulthood, age 40 to 65. So note your ages. Young adulthood is 19 to 40. Middle adulthood is 40 to 65. In general, people in middle adulthood are more comfortable and stable than they were before. Many of their major life decisions have already been made. Physical changes related to aging occur in middle adulthood. Adults in this age group may notice that they have difficulty maintaining their weight. They notice an increase or decrease, I should say, in strength and energy. Metabolism and other body functions slow down. Wrinkles, gray hair appear. These disorders can become chronic and life-threatening. So take care of yourself in your young adulthood so you will be better in the middle and late. Late is 65 and older. Persons in late adulthood must adjust to the effects of aging. These changes can include loss of strength and health and death of loved ones, retirement, preparation for their own death. The development task this stage may seem to be entirely with loss. Later adulthood covers an age range anywhere from 25 to 35 years. You sure want to live as long as you can. 70-year-old people, they're out there enjoying active sports, while others are not active. Some 85-year-old people still live alone. Some people are in long-term care facilities. Don't assume that everybody is in a nursing home. If there was, the nursing home would be 5 and 6 stories, every one of them. Ideas about older people are often false. They create prejudice against the elderly. Just as unfair as prejudice are against racial, ethnic, or religious groups, it's unfair against the elderly. They actually have a name for that. If you look over there above the picture, it's called ageism. That is prejudice toward, stereotyping of, and or discrimination against older persons. Everybody ain't slow. Everybody can't drive. Everybody, can't understand. They don't know what's going on. But that is called ageism. When you feel some kind of way because they're older, and tends to be disrespectful. Nursing assistants are likely to spend much of their time working with elderly. They must be able to know what is true about aging and what's not true. Aging causes many changes. However, normal changes of aging do not mean an older person must become dependent, ill, or inactive. Knowing normal changes of aging from the signs of illness will allow NAs to better help their residents. Normal changes of aging include, and there's lots of them, we're going to learn that it keeps on going. Skin is thinner, drier, more fragile, and less elastic. Muscles weaken and lose tone. Bones lose density and become more brittle. Sensitivity of nerve endings decrease. Responses and reflexes slow, underline that. Short-term memory loss occurs. Sense of vision, hearing, taste, sound, touch, smell weaken. Heart works less efficiently. Oxygen in the blood decreases. Appetite decreases. I'm still waiting on that. Underline urinary elimination is more frequent. And digestion takes longer and is less efficient. Underline that. And underline levels of hormones decrease. Underline immunity weakens. All of those are very important. It's gonna happen. It's normal. We don't like it. We get older and things happen, but that does not mean anything stops or becomes diseased. Anything that is associated with a disease is not normal. There are also changes that are not considered normal, which is your depression, any loss of abilities to think logically. You should be able to think logically up until the day you die. Poor nutrition, shortness of breath, and incontinence. A lot of people think incontinence is normal. No, I don't want to be incontinent when I get old. As long as you're calling it normal, then that means I have to be incontinent. I will have urinary elimination being more frequent. I will have oxygen in my blood decrease, but it's not necessarily I'll be incontinent. Everybody's not incontinent. So that is not normal. Discuss developmental disabilities. Developmental disabilities are disabilities that are present at birth or emerge during childhood. They are in the development. They're born with it, congenital, and then we have to take care of them from that point. It restricts physical and mental ability. These disabilities prevent a child from developing at a normal rate. Language, mobility, and learning, and the ability to perform self-care may be affected. The care residents need will depend on the type and the extent of their disability. And you've seen different types of, they have borderline people to people that are just, in their bed, can't do anything else. And it really depends. An intellectual disability, we used to call mental retardation. It's a type of development disability that is neither a disease nor a mental illness. People with an intellectual disability develop at a below average rate. They have below average mental functioning. They have difficulty learning, communicating, moving, and may have problems adjusting socially. Their ability to care for themselves may be affected. There's different levels of that also. Mental retardation all the way to your borderline that works at Flowers Bakery for 30 years, goes to work every day, pays all his bills on time, but cannot get in an argument. He wants to kill people, because he cannot handle emotional distress. And that is an actual person that I know. But you wouldn't know it. He goes to work. I'm telling you, he's the best worker they've had, and he is a hard worker. But when it comes to emotional issues, he just goes overboard. But he is that borderline. They still call him mental retarded, but he actually does much better than a lot of people I know that aren't mental retarded. Despite their special needs, people who have an intellectual disability have the same emotional and physical needs as others. Underline that. They have the same emotional and physical needs as others. They experience the same emotions, such as anger, sadness, love, and joy, as others do. But their ability to express their emotions may be limited, or handle their emotions may be limited. That's another good way to sit it, too. Guidelines for intellectual disability. Treat adults as adults. Praise and encourage them often. Help teach their ADLs. Sometimes they just don't understand what's going on. It really depends on what level they're at. Sometimes they are almost bedbound, and a lot of them are. But some of them are walking, talking. You got to watch them. They're very strong people most of the time, and get them mad if you want. Promote independence. Assist residents with activities and motor functions that are difficult. Encourage social interaction. Repeat words you use to make sure they understand. And be patient. Describe some types of mental illness. There's different types. We got depression, which is a clinical depression. It's a serious mental illness. It may cause intense mental, emotional, and physical pain and disability. Depression also makes other illnesses worse. If left untreated, it may result in suicide, and we do not want anybody hurting themselves or killing themselves. Clinical depression is not a normal reaction to stress. Sadness is only one symptom of the illness. Not all people have depression complain of sadness. They might not even ever tell you, but they are not feeling good. They might not even not appear sad, but they are depressed. Sometimes common symptoms of clinical depression are pain, including headache, stomach pain, other body aches, they low energy, apathy or lack of interest in activities, irritability, anxiety, loss of appetite, overeating, problems with sexual functioning, Sleeplessness or trouble sleeping, lack of sleeping, too much sleeping, all that can be problematic. Lack of attention to their basic personal care. Someone who used to just always be all dressed up every day, and then suddenly they just want to stay in their, pajamas. Something's going on with them. Intense feelings of despair, guilt, trouble concentrating, withdrawal, isolation, repeated suicide threats or thoughts of suicide and death. That could be your clinical depression. There are different types and degrees of depression. We've got major depressive disorder. It's or they call it major depression. It may cause a person to lose interest in everything they once cared about. That person they used to just care and be all out and about, and something happened. No telling. It could be a death in the family. It could be boyfriend broke up, a husband cheated. All kind of things can really mess up somebody. That is your depressive disorder. Bipolar disorder is also called manic depressive illness. Causes a person to swing from deep depression to extreme activity. A lot of people think they have bipolar, but they don't. This is real. Manic meaning they are running around the place. They are spending a lot of money, dressing in all kind of ways. They are high on life, which is a nice feeling. Sometimes they get a little bit too fast and just spend all their money, or just mess up all things. They don't go to work. But that's the manic side. The depressive side is different. They're very sad and they swing, and don't swing like daily. That's normal. Now I always have to say this, because people say they have bipolar because they're happy one minute, next minute they're mad. Probably because something made you mad, or you didn't like something that happened. Just maybe you're just spoiled rotten. You just don't like something, and that's not a mental illness. That's not bipolar. That's you not liking something. You can get angry and then you can get sad. Those are normal reactions. These people stay in a depressed mood for like 6 months at a time, and then in 6 months they're like total different people because they're running around just high on life. That is bipolar. People cannot overcome depression through sheer will. It's an illness like any other illness. So people cannot overcome depression through will. It can be treated though. People who suffer from depression need compassion and support. NA should know the symptoms so they can recognize the beginning and worsening of depression. Any suicide threat should be taken seriously. Never assume that it's an attempt to get attention. But make sure that we are reporting that too. Somebody tells you they want to kill themselves, take it seriously. Don't play with it. Anxiety-related disorders. Anxiety is an uneasiness or fear, often about a situation or condition. When a person who is mentally ill or mentally healthy feels anxiety, he usually knows the cause. A person who is mentally ill may feel anxiety all the time. He may not know the reason. Physical signs and symptoms of anxiety-related disorders include shakiness, muscle aches, sweating, cold and clammy hands, dizziness, fatigue, racing heart, cold, hot flashes, choking, smothering sensation, dry mouth. I've had real anxiety back when I knew that somebody was coming and trying to cut me with a knife, and I just didn't know what to do. I wanted to fight, but she had a knife, and those feelings were crazy, and I was shaking, and we was about to fight. But that was true anxiety. I've seen all them physical attributes, but that is not. I knew what the problem was, so I'm mentally healthy. That's what we say. But a mentally ill may not know where the feelings come from. A phobia is an intense form of anxiety or fear. Many people who are afraid of some things or situations. Example, a fear of dogs or a fear of flying. For a person who has mental illness, a phobia is disabling terror. It keeps the person from doing normal things. For example, a fear of being in a confined space called claustrophobia can make using an elevator terrifying. And what if that's the only way they can move up and down? Or maybe they live on the 50th floor. Why would they do that if they're claustrophobic anyway? Maybe they like exercise. But it can cause them not to be able to function daily. Other anxiety-related disorders include panic disorder, in which a person has repeated episodes of intense fear that something bad will occur. They really don't know what's happening. They swear they're about to die or they can't breathe. That is your panic disorder. Obsessive compulsive disorder, or OCD, is an anxiety disorder characterized by excessive behavior or thoughts. For example, a person may wash his hands over and over as a way of dealing with anxiety. Anxiety-related disorders may also be caused by a traumatic experience. This is known as post-traumatic stress disorder. Something happened, traumatic, and this is afterwards, and something reminds them, so they have post-traumatic stress disorder. Schizophrenia is a brain disorder that affects a person's ability to think and communicate clearly. It also affects the ability to manage emotions, make decisions, understand reality. It affects a person's ability to interact with people. Treatment makes it possible for many people to lead relatively normal lives. So we can treat a mental illness by medication. We cannot treat an intellectual disability, that's mental retardation. They're going to be there. We can try to get them to do steps and learn. They're going to be a lot slower, but that is intellectual disability. Some of the signs of schizophrenia, however, are hallucinations and delusions. A hallucination are false or distorted sensory perceptions. A person may see something that's not really there or hear a conversation that's not real. That is a hallucination. And we always say, Michael Jackson, he's standing there, that is hallucination. You see him. You hear him singing, that is a hallucination. A delusion is persistent false beliefs. For example, a person may believe that other people are reading his thoughts. Paranoid schizophrenia is a form of the disease that centers mainly on hallucinations and delusions. Not all hallucinations or delusions are related to schizophrenia, however. Sometimes it's medical. Something's happening to them. Maybe if they're having alcohol detox, that can also do it. But a delusion is actually a wrong belief. Like, I believe I'm Michael Jackson. That's a delusion. A hallucination is hearing, seeing that Michael Jackson. Mental illness. Observe residents carefully for changes in condition or abilities. Support the resident and her family or his family and friends. Encourage residents to do as much as possible for themselves. Mental illness can be treated. Medication and psychotherapy are common methods. Medication must be taken properly to promote benefits and reduce side effects. Psychotherapy is a method of treating mental illness and involves talking about one's problems with mental health professionals. That's when you sit on the sofa and talk about it. And sometimes that helps. That's called psychotherapy. Or you can get medications. A lot of times it is hormonal issues, and maybe we can fix it. Observe and report for mental illness. Changes in ability. Any positive or negative mood changes. Any behavior changes, including changes in personality, extreme behavior that does not seem to fit the situation. Comments, even jokes about hurting themselves. Failure to take medication, real or imagined physical symptoms. Events, situations, or people that seem to upset or excite your residents. So we are trying to make sure that we're trying to avoid upsetting them, and observe and make sure they're not trying to hurt themselves or anybody else also. Intellectual disability and mental illness. Some people confuse the terms intellectual disability and mental illness. They are not the same. An intellectual disability is a developmental disability that causes below average mental functioning. It may affect a person's ability to care for themselves as well as to live independently. It is not a type of mental illness. An intellectual disability affects mental ability. Mental illness may or may not affect mental ability. You've got to know that intellectual disability affects mental ability, whereas mental illness may or may not. There is no cure for intellectual disability, although persons who are intellectually disabled can be helped. But many mental illnesses can be cured with treatment, such as medications and therapy. So with how they worded that and how they spaced that out, they didn't space it right for me. But what they're trying to say is mental illness can be cured with treatment, whereas intellectual disability cannot. Number 10, page 69. Explain how to care for dying residents. Death can occur suddenly without warning or can be expected. Older people or those who with terminal illness may have time to prepare for the death. A terminal illness, we already know what terminal means, is a disease or condition that will eventually cause death. Preparing for death is a process. It affects the dying person's emotions and behavior. Dr. Elizabeth Kubler-Ross studied and wrote about the grief process. And it is a process when you know you're dying or when you're trying to accept any kind of grief. The first stage, there's 5. Denial. They're in the denial stage. They refuse to believe that they're dying. They often believe a mistake has been made. They may avoid even discussion about it or pretend it's not even happening. Anger. Once they start to face the possibility of their death, people may become angry that they're dying. They may be angry because they think they're too young or they've always taken care of themselves, so they're angry now. Then comes bargaining. Once people have begun to believe that they're dying, they may make promises to God, care providers, and others. They may somehow try to bargain for their recovery. Like, okay, God, if you just let me live to see my grandson graduate, or if you let me see my daughter have her child, that is bargaining. Depression. As dying people get weaker and symptoms get worse, they become deeply sad or depressed. They may cry or withdraw or be unable to do even simple things. So that is your depression stage. And this is of your grief process. Acceptance. Many people who are dying are eventually able to accept death and prepare for it. They may arrange with loved ones for the care of important people or things. They may make plans for their last days or for the ceremonies that follow. And that's where you want everybody to be. And I had that on my LPN test and my RN test. So those are phases that you need to be familiar with. DABDA. D for denial, A, anger, B, bargaining, D, depression, and then A, acceptance. DABDA. D-A-B-D-A. Then we have things such as advance directives. Those are legal documents that allow people to choose what medical care they wish to have if they're unable to make them themselves. A lot of people do this before. They call it advance for a reason, because they do that before they get sick, before they can't make those decisions. They're making this ahead of time. That's what an advance directive is. There's examples, or there are 2 types listed here of an advance directive. One is a living will. A living will outlines the medical care a person wants or doesn't want in case he or she becomes unable to make those decisions. It is called a living will because it takes effect while the person is living. They're not dead, they're living. It may also be called a directive to physicians, healthcare declaration, or medical directive. Most of the time we call it a living will. A living will is not the same thing as a will. A will is a legal declaration of how a person wishes his or her possessions to be disposed of. That's a regular will. A medical will is a living will in medical care is one that you say, okay, if I don't have any brain function, I want you to still feed me through a tube for however long. Hopefully I will come out of my coma. If you get into a coma, what kind of care do you want? Do you want them to cut off the food in your veins? Do you want them not to give you water? What kind of care would you like? Do you not just want to stay on a ventilator if you ever are put on a ventilator? Those are your decisions, and in advance, you're making those. Another advance directive is called a durable power of attorney. All you're doing is you're giving power of attorney for someone else to make those decisions. The doctor explains the care that they can do. Maybe you're unconscious. Maybe you can come back. But instead of just being point blank, this is what I want, this is not what I don't want, they allow someone else whom you trust to make those decisions. If you don't have that, or if you have neither, most of the time they're going to have your husband doing it. If you're married, or oldest child, or closest sister, hopefully family will help decide that, not just overrun you with it. Do not resuscitate is also an advance directive. It's you saying, I do not want you to perform CPR on me. If I die, let me go. Don't try to bring me back from the heavenly gates. And that is what a DNR is. Do not perform resuscitation. Do not do CPR on me. Residence rights for advance directives. By law, advance directives and DNR orders must be honored. Nursing assistants should respect each resident's decisions about advance directives. This is a very personal and private matter. NA should not make comments about residents' choices to anyone, including family members, other residents, or staff. Death is a very sensitive topic. Many people find it hard to discuss. Feelings and attitudes of death can be formed by many factors. Your experience with death, your personality type, religious beliefs, cultural background, all can affect how you feel. Not that you're not saying, not that you don't miss the person, not that you didn't love them to death. It's just how do you deal with that? And people are different. Guidelines, caring for a dying resident. First thing to know and realize that the diminished senses are going to happen. So you want to reduce glare, keep the room light and low. Also, underline, hearing is usually the last sense to leave the body. So I always continue to talk to them, even when people think they're really gone, they're just laying there. Still talk to them up until their last breath. I believe it's still there. Because I've even heard people say they coded and they still heard somebody tell them to come back. So just know that may be soothing to that patient. Or don't talk about them while they're there like that, because they might still can hear you. Care of the mouth and nose. You're still going to take care of this patient just like they were sitting right there. But for the patient that breathes out their mouth, you're going to have to do more care for them. They may live and keep living. You're going to have to take care of that mouth. And they're going to do mouth care every 2 hours. We keep their mouth brushed, and we have, because what happens is the saliva or the lack of causes it to get hard in the mouth. And it actually makes a film that almost is like a white film, and it gets hard. And it attaches to the tongue, the top layer of the tongue at that. I actually had a patient where I seen that. And I wanted to just pull up the white hard part, but my teacher was like, oh no, that is attached to them like a scab would be. That's why you have to do very good mouth care. They're mouth breathers. Then you need to be using that sponge, get in there and clean. Skin care. Get bed baths and incontinence care is needed. Bathe perspiring residents often. A lot of times they're perspiring. You still got to take care of them just like they are going to live to be 1,000. Comfort, pain release is critical. Residents may not be able to tell you that they're in pain. Observe for signs of that pain. Report them. Frequent changes of position, back massage, skin care, mouth care, proper body alignment, all that may help. Make sure the environment, put their favorite objects around them, pictures, put the call light within reach still. They may wake up and push the call light, and that may surprise the mess out of you. But do that anyway. They may wake up. Emotional, spiritual support, if they want a preacher, if the family wants preachers, give them that. Do as much as you can for the family without, you can't give away stuff or whatever, but you can do as much as you can for the family. Some residents may seek spiritual comfort, especially don't judge them either, because sometimes people don't even think about God until they are almost about to die on their deathbed. And when they ask for God, I don't want to be that person who thinks they are Catholic and they don't get to confess their sins. Imagine that feeling that I'm about to die. I'm about to die now. I done accepted I'm about to die, and I can't get hold to a Catholic priest so I can confess my sins, because they believe they have to go through that priest to confess their sins. So I would be finding me a priest, and I don't want to deny anybody or make them even feel that way. They have the right to refuse treatment still. No matter what's good or bad, they still have that right. They have the right to visitors. They have the right to privacy. On page 71, this is called the Dying Person's Bill of Rights. It's actually really kind of sad. I don't like to read it. The Terminally Ill Patient and the Helping Person, sponsored by Southwestern Michigan and in-service educational thing. The Dying Person's Bill of Rights. The dying person says this: I have the right to be treated as a human being until I die. Maintain a sense of hopefulness, however changing its focus may be. Be cared for by those who maintain a sense of hopefulness, however changing this may be. Express my feelings and emotions about my approaching death in my own way. Participate in decisions concerning my care. Expect continual medical and nursing interventions, even though cure goals must be changed to comfort goals. Not to die alone. Be free from pain. Have my questions answered honestly. Not be deceived. Have help from and for my family in accepting my death. Die in peace and dignity. Retain my individuality and not be judged for my decisions, which may be contrary to the beliefs of others. Discuss and enlarge my religious and or spiritual experiences whatsoever or whatever these may mean to others. Expect that the sanctity of the human body will be respected after death. Be cared for by caring, sensitive, knowledgeable people who will attempt to understand my needs and will be able to gain some satisfaction in helping me face my death. It's just terrible. but that is the dying person's Bill of Rights. Guidelines: treating dying residents with dignity. Respect their wishes. Sometimes they can't do a lot for themselves, but you are showing his utmost respect and dignity to the dying person. Don't believe that they don't feel it. Don't think that they are not realizing that you're not paying attention to them, or that you're just looking straight over them. They're still there, and treat them as such. Do not isolate or avoid the resident. Be careful not to make promises that you cannot keep. Continue to involve the dying person in facility activities if they can. Try as much as you can. Listen if the dying resident wants to talk, but don't offer advice. Do not babble or act especially cheerful or sad. Be professional. That especially cheerful mess and my mother is dying might not work. I might think you're not professional because you're a little bit too happy, and my family is experiencing a terrible pain or loss. So be careful with the cheerfulness. Be happy. Be friendly. Be yourself. But there's that extreme cheerful, happy, it's a wonderful day, not appropriate. Keep the resident as comfortable as possible. The nurse needs to know immediately if pain medication is requested. Assure privacy when it's desired. Respect the privacy of the family and other visitors. They may welcome a friendly smile, however, and should not be isolated. They may be upset and not want to be social. I've read that backwards, but sometimes they like family, sometimes they don't. Help with family's physical comfort. If requested, get them coffee, water, chairs, blankets, something you can do to help them also. Common signs of approaching death include blurred, failing vision, unfocused eyes, impaired speech, diminished sense of touch, loss of movement, muscle tone, feeling, a rising or below normal body temperature, decrease in blood pressure, weak pulse, alternating periods of slow, irregular respirations, and rapid, shallow respirations. It's called Cheyne-Stokes. If you ever hear it, you will know that's the death rattle. That sounds like a terrible, weird kind of snoring that it's kind of scary. So it's slow and irregular, then rapid and shallow. It's scary sounding. I can't even do it. But if you ever hear it, you'll be like, oh, that's what she was talking about. They're called Cheyne-Stokes respirations. A rattling or gurgling sound as the person breathes, cold, pale skin, mottling or a bruised appearance, spotting or blotching of the skin. That's all caused by poor circulation. Perspiration, incontinence, both urine and stool, disorientation or confusion. When death occurs, the body will not have a heartbeat, pulse, or respiration, or blood pressure. The muscles in the body become stiff and rigid. This is called rigor mortis, which is the Latin for stiffness of death. That can be a scary thing too. The eyelids may remain open or partially open with the eyes in a fixed stare. The mouth may remain open. The body may be incontinent of urine and stool. Though these things are a normal part of death, they can be frightening. NA should inform the nurse immediately to help confirm the death. Postmortem care is care of the body after death. It takes place after the resident has been declared dead by the nurse or doctor. NAs must be sensitive to the needs of the family and friends after death. Family members may wish to sit by the bed. They may want to talk to or look at the body for a while. You must allow those things. NA should be aware of religious and cultural practice that the family want to observe. Make sure we're not disrespecting that body. That person has died, and the family may want to just talk to them, and maybe they're waiting for the rest of the family to come and help make decisions about the nursing home or what's going to happen. Just give them that time. Guidelines for postmortem care. Bathe the body. Be gentle to avoid bruising. Place drainage pads where needed. This is most often under the head or under the perineum, because they may be, leaking out their orifice. Follow your standard precautions, because that's still bodily fluids. Do not remove any tubes or other equipment. A nurse will do that, or maybe the funeral home people might. If instructed, put dentures back in the mouth, close the mouth. A lot of times it's not possible because they've done got that stiffness of death, and we put those dentures beside their head. Close the eyes carefully. Position the body on the back with their legs straight. Fold the arms across the abdomen and put a small pillow under their head, just like they would be positioned in a nursing home. In a coffin. Follow facility policy on personal items. Check to see if you should remove jewelry. Always have a witness if personal items are removed or given to a family member. Document what was given to whom. That's an awful thing because they took my mama's rings off her hands and ended up giving them to the oldest son. But she always said she wanted to be buried with those, especially her wedding ring. So it kind of made me mad, very mad. Strip the bed after the body has been removed. Open windows to air the room as needed. Straighten up. Document according to your facility's policy. Dealing with grief after death of a loved one. Dealing with grief after the death of a loved one is a process. Grieving is an individual process. No two people will grieve in exactly the same way. It's also a changing or adaptive process. Feelings may change from day to day or even hour to hour. This is normal. Clergy, counselors, or social workers can help people who are grieving. Family members or friends may have any of these reactions to death. You can't tell how someone's going to react. They may be in shock. They may still be in shock all the way up until the funeral. They may be in denial. They may be angry, guilty, regretful. Maybe they didn't do something that they promised they would do, and I promise you, people remember stuff like that. And my friend, he says it all the time. You know, I told her I would bring her some pads, incontinence pads, to her, and I never got them to her. I guess he acts like she had some, but it bothers him that he did not do what he said he'd do before she died. Sadness, loneliness, them things happen. Now, this is before death, and we're going to talk about the hospice program. That's number 11. Hospice care is a term for special care that a dying person needs. It's a compassionate way to care for dying people and their families. Hospice care uses a holistic approach and treats the person's physical, emotional, spiritual, and social needs. Hospice care can be given 7 days a week, 24 hours a day. It's available with doctor's order. Hospice care may be given in a hospital, at a care facility, or in the home. A hospice can be any location where a person is dying and treated with dignity by caregivers. Any caregivers may give hospice care, but often specially trained nurses and volunteers provide it, because you have to have a special heart for hospice, and I just know that I can't take care of people when I know they're dying and I want them to live forever. Also, I don't want to give that morphine at the end of life when they are in so much pain that morphine's going to take them out. Don't want to do that either. So you got to be that special person, and to be that CNA, you're going to see them, especially when they first get diagnosed hospice. They may be walking around talking, and the next thing you know, they're just not talking, not moving, not eating. You barely can help them. You can keep them clean and dry. And so those are terrible situations I don't like. Hospice care helps to meet all the needs of the dying resident. The resident, as well as family and friends, are directly involved in the care decisions. The resident is encouraged to participate in the life and decision making as long as possible. They're making decisions for themselves all the way up until they can't. In long-term care, goals focus on recovery and the resident's ability to care for themselves and get as much progress as needed. But in hospice, the goals are different. Now it's comfort, dignity of the resident. Underline comfort and dignity, also known as palliative care. Hospice care equals palliative care. What we're doing is comfort and dignity. That also includes your pain relief. So I might as well say comfort, dignity, pain relief. Comfort is included in pain, but comfort, dignity, and pain relief is palliative care, and that's the care that they receive in hospice when someone is told that they have 6 months or less to live. Residents who are dying need to feel independent for as long as possible. Caregivers should allow residents to have as much control over their lives as possible. Eventually, caregivers may have to meet all of the person's basic needs, and that's what happens at the end. Guidelines for hospice: be a good listener. Some people, however, may not want to even talk or even confide in you. They don't know you that well, but they need you. They appreciate your help, but they're not going to talk to you. Respect privacy and independence. Be sensitive to individual needs. Ask family members or friends how you can help. Be aware of your own feelings. Know your limits and respect them. Recognize the stress. Talking with a counselor or support group may help. Remember, however, that specific information must be kept confidential. You can talk about what's going on with your patients. You cannot tell them, again, you cannot tell them their names. Take good care of yourself. Eating right, exercising, and getting enough rest are ways of taking care of yourself. Talk about and acknowledge your feelings. Take time to do things for yourself. Take a break when you need to. It's taxing you, and you know that you're taking care of someone who is, gonna die. Allow yourself to grieve. You will develop close relationships with some residents. Know that it's normal to feel sad, angry, or lonely when residents die. And that's a natural part of life. That's the life, circle of life. And don't nobody like it, but that's what happens. Community resources. They are a whole page of these. I want you to turn to page 74. And if you have any older people that needs any of these resources, please give them these numbers. They are wonderful numbers. They're beautiful numbers that people need to be aware of. Some people don't even know about these numbers or the community resources, and I just even looking at it am amazed that there's so many things that are going on around us: elderly, advanced aging, areas of aging, that we can talk to and talk about. We could do that. So know that was your chapter 3, and we are done with chapter 3. But those are your numbers. They are wonderful. Give them to somebody who needs them.